Now, the next point and the last point in our emergency medicine class would be the trauma and trauma management. Now, trauma can occur in any situation, unexpected situation, and whether the patient had any pre-existing pathology or not, or whether the patient is otherwise healthy or not. These are all the issues which can produce a huge change in the outcome. And another important problem is when the trauma occurs, the patient may not be in a position to exactly point out which sort of the area is involved or what sort of the complications have occurred. The assessment would be very complicated, and hence there are a lot of different management or different systems of scoring in or assessing the conditions of trauma. So in a traumatology, in case of the casualty, when a patient comes with a history of trauma, the complex issue would be to assess the impact on the anatomy and the physiology, as well as the possible the other complications which can occur due to the trauma. And then the acute management. There are lots of these assessment methods, like lots of methods are practically used, but the most popular methods which are used, I'll just refer to the common and most popular methods are, the one is a physiological score. The physiological score, you have to assess the Glasgow Coma scale, which we have already discussed in the previous condition. Then the blood pressure, systolic blood pressure, respiratory rate. These are the three important, the primary issues. Once the patient with the trauma comes in, you have to assess the Glasgow Coma scale, and then there is a scoring method. Now, this becomes a very complicated mathematics, but at the end there is some easy alternative. So I am just saying about this. If the Glasgow Coma scale is 3 or less than that, then it's a 0. If the Glasgow Coma scale is 13 to 15, that's almost the patient is fully conscious and no injuries, its a scale is 4. Systolic blood pressure, if it is 0, not recordable, then again the score is 0. And of course, if it is more than 90, then 90 millimeters of mercury, the score is 4. And respiratory rate 10 to 30 is the normal range, then it's the scale is 4. So normal healthy person, the score would be 4 in each of these categories. And the same would be calculated based upon the formula of 0.9368 of Glasgow Coma scale plus 0.7326 of systolic blood pressure plus 0.2908. Now, this looks like a very complicated mathematics, but of course there are certain easy methods of doing this. The easy methods of doing this would be, if you go a combination of these before that, another scoring system would be the injury severity score. That's the anatomy score. If the injury severity score, it's if the head and neck is, if there is no injury, of course the score is 10, and if there is no injury, then 0. If there is a single cerebral contusion, then the score is 9, and chest, if there is a plain chest, it is 16. If the abdomen, liver laceration and completely shattered spleen, then 25 plus 16. If there is a fractured femur, the score is 9. Externally no injury, then the score is again 0. So injury severity score totally is 50. Now, when anatomy and physiology score both are combined, then there is another added, the biochemical parameters, that becomes acute physiology and chronic health evaluation, or Apache ICU scoring. Now, Apache ICU scoring is a very regularly used in the ICUs, patients who are in the ICUs, where along with our physiological variables as well as the anatomical variations, you measure the other parameters like temperature and the heart rate, respiratory rate, oxygen concentration, and serum sodium and potassium chloride and creatinine levels, which again about the chronic health evaluation. There you have the two aspects, acute physiology and the chronic health evaluation, which gives you a prediction about the possible outcome. So Apache scoring now has become standard, and the whole calculations, all that mathematical models, they are made easy by these websites. Or now even you have a mobile app where if you feed these factors, you get the score. You don't have to go for that complicated calculation of having these multiple factors and so on. So you put the score of these observations, and then you get the score as such. So you may try in any of these websites. There are two of the very popular websites which are used regularly, or even there is a mobile app which is available in the Google Play Store, also Apache scoring app. So that's the other way. And ultimately, another easy method, now this is one alternative. The other way would be you can have another usual scoring like the abbreviated injury scale, where anatomy and physiology scoring are added together, and then you come to a final. Like if the score is a 6, then it's unsurvivable. If it is a 1, it's minor. Of course, no score, 0 is a normal. So in between, you can predict the prognosis. So one of the important issue in case of any trauma patient is to assess which of the organ is involved, and how much is the severity of the intensity, and whether the patient had a pre-existing disease which has affected the physiology or not, and then you predict the prognosis. Prediction of the prognosis is one of the issues. That's in case of the casualty. Now, of course, then the other aspects of the management, I will come to that. Now, another common issue in the clinical practice would be mass casualty, though may not be seen in our hospital. In our hospital, that chances are lesser. But if we are working in any other major hospitals, mass casualty, where the accidents or any other sort of things, where large number of people with injury comes in that condition, there are certain principles. And in that steps of the dealing with the casualty management, now, though it may not be very practically useful in a Ayurvedic hospital as such, you need to know about these principles. That's why I'm just casually referring to these issues. In such a mass casualty, the primary 5 approaches are triage, primary survey, secondary survey, treatment of emergency treatment, where particularly it's the pain management. So I'll come to that. Then the last part is the documentation. In every case of casualty trauma, the documentation is very important, and it also may have a legal value which can have very critical impact on the career of the physician, or it could have a lot of vital aspect in the life management of the patient, and hence documentation is very important. The other principles, triage, primary survey, secondary survey, treatment, we will go into that. Triage is a principle of doing greatest good to the greatest possible numbers. See, when there is a mass casualty, large number of patients with the injuries, if you focus on only 1 or 2, and then at the end the result is poor, the outcome is poor, it will not be helped. So the scope of reaching to the maximum and gaining the maximum advantage. So if there is a possibility of benefiting a patient, you do that. If there is no possibility of benefiting the patient, you do not do that. That's the basic principle of the triage. That's exactly what Sushruta has said is sadhyan sadhayet yapyan yapayet asadhyan nayopakrameda parisamotsarotitan shivikaran prayashavarte. That is the same principle, or what Charaka has said as maitri karunyam artheshu shakya priti upekshanam prakritisteshu bhuteshu upekshanam also is a basic principle of the triage as such. So the important is you have to identify the patients who have an immediate life-threatening condition and who are in a better position. And there is a general universal rule of triage categories. Triage categories are usually with the color coding, standard, universal. This, at least, though we may not be Ayurvedic students may not have that opportunity of going into that, but you need to know about these issues. A green is always a minor injury, yellow is delayed or immediate requirement is red, and the black is a poor prognosis, whether only when you have a facility. Now, what happens is, in a case of mass casualty, the principle would be the first team would be reaching to the area of that accident or where these victims are there, and in such condition, you have to, one group would be reaching to the people and the casualty, and then putting a sticker, colored code over the patients, like which is having a minor or which is require an immediate expectant treatment or immediate treatment like emergency conditions, and so on. So you then, once this is done, this basic triage is done, the patient is shifted to the hospital based upon the requirement. Minor injuries can be treated at the same site itself or maybe taken to a center where the facilities are lesser. The patients with the red tag, they need to be taken to a hospital where you need to have the facilities like ICU, so that every person can get a equitable opportunity and the resources are utilized properly. If all the patients are taken to a single health center, then you will have a lot of chaos and all may not be able to be attended. So this kind of a concept of triage is a basic idea of all that conditions. Like now when I say this color code, the color code would be green is ambulatory, yellow is injured, red is critically injured, which requires immediate attention, and the patients are taken to a center where you have a better facility. Green is taken to a center where the facilities are lesser. Black is almost dead, when patients are unresponsive and there is no need of taking to the patient to a facility where health facilities are available, but the other way. So once you have categorized the casualty conditions, the next part is about the shift of the patients, transfer of the patients to the area. Patients who are in the red condition may require an immediate life support at the site and then may be taken to a center, so on. So these are the basic ideas of the triage which are used. So I will not go into much of the detail, but you need to have a sensitized about these concepts as such. Then the issue is about the primary survey. Once the patient is brought in, you have to survey, and this survey would be, the first would be airway and breathing and ventilation, circulation and hemorrhage controls, which these three factors we have already discussed in different aspects of the emergency. Airway, breathing and ventilation, and the support cardiopulmonary resuscitation issues we have already, and even hemorrhage and the management of the hemorrhage we have discussed. Then the other two factors are disability neurological functions. Like if the patient has a neurological deficit, that has to be supported. Like suppose if the patient is not able to control the bowel or control the bladder movements, you may have to put a catheter in. If the patient is not able to swallow, you decide whether the patient can be maintained on a rail tube feeding or otherwise, so on and so forth. And then the environmental control, the whole area where the patient is, these casualties are another major problem would be the onlookers, the people who come in and then intervene. That's also another factor which has to be considered. Then secondary part would be going for the basic investigations and decision about the area of specialty required. Like if the patient has a fracture, the patient has to be referred to orthopedic center. If the patient has a neurological injury, a neurologist, or so on, or multiple specialties, so on, and then planning of the treatment. That's about the total protocol of dealing with the casualty. And then of course the next part would be based upon the injury and based upon the facilities available, a specific treatment is to be followed. So I will not go into that part in detail. Instead, the other one of the important issue in case of every casualty is the pain management. The first of the thing would be the pain management, irrespective of the specialty. So I will be focusing on the pain management, and we end up the chapter now. We will not go beyond that. Now, pain as such is defined as, definition of pain is again very complex issue. In the contemporary science, the definition of the pain till 1979, or rather a model, the definition which was established in 1979 was an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. Then this definition didn't satisfy many of the people, and then there was a group of presidential multinational task force to redefine the pain in 2018, and the latest of the definition, which was presented in revised in 2020 by the International Association of the Study for Pain, is unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Whether there is an actual or potential tissue damage, an unpleasant emotional experience, including the class, can be defined as pain. And the pain is simple pain as a diagnosis can be is accepted by the ICD as a code of R52. Now, because the whole definition is a very complex issue, and these definitions are revised frequently. There is some notes also, the added notes also. These again, the notes which are added, which make that definition clear, are pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. This is a very important issue. The same amount of a tissue damage may not produce the same amount of pain in every person. Some may feel more pain, some may feel less pain, some may be more sensitive to the pain, which depends upon the psychological, social factors. Then pain and nociception are different phenomena. Pain cannot be inferred solely from the activity in sensory neurons. So pain feeling cannot be objectively measured. You do not have any neurological technology which can measure the pain. It's not simply the nerve function. There is something more than that, which is not clearly understood. Then, depending upon the life experiences, the concept of the pain may vary from person to person. Some may feel that this pain is acceptable, some may feel that the pain is not accepted, or some may get adapted to the pain. Certain amount of the pain is accepted. So this also should be the other factors. Then, of course, the other criteria is a person's report on an experience as pain should be respected. Even if there are no any objective reasons, you have to accept that the patient has a pain if the patient says that there is a pain. And you may call it as functional, but anyway, pain has to be accepted. Then although pain is usually having an adaptive role, it may have an adverse effect on the function and the social and psychological well-being. Now, adaptation of the pain is another of the important issue. Any person who has a pain for a long duration may adapt to that, get conditioned to that, and he may not really experience the trouble or unpleasant experience of the pain. But still, it may have a physiological impact, and hence it needs to be treated. That's all the issue. Then verbal description is only one of the several behaviors of express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences the pain. Now, this is another very significant issue from the anesthesia point of view. If the person is not able to express the pain, it doesn't mean that the patient doesn't have the pain. Now, this is true in patients who are given the skeletal muscle relaxants. In anesthesia, general anesthesia, you have the two issues. One, the anesthetics, and the other is skeletal muscle relaxants. And usually, to minimize the dose of anesthesia and to have a safe stage of surgery, we support the stage of anesthesia with the skeletal muscle relaxants. Skeletal muscle relaxants will have other benefit also. Persons who are on skeletal muscle relaxants, it helps in, of course, exposure of the field of surgery, because the muscles are relaxed, they can go deep into the body. Beyond that, another advantage of the skeletal muscle relaxants is that the patient would not be having that reflex action of the pain. See, reflex action of the pain is once there is a pain, usually you will try to withdraw from the source of the pain. You will try to move that part of the body which is having the pain away from the source of the pain. In a patient who is under skeletal muscle relaxant, he cannot do that. But at the same time, the experience of the pain has to be reduced by combining it with the anesthetic drug. So when we give skeletal muscle relaxant, the quantity of anesthetic drug can be reduced. But if it goes below certain level, then though the patient may not be able to express the pain, the impact of the pain in terms of the blood pressure, in terms of the pulse rate, or at times the tears coming through the eyes can be seen in a patient under anesthesia. And an anesthetist has to maintain that level where the patient doesn't experience the pain. Otherwise, so that's all. The point is same, like even if the patient is not able to express the pain or communicate that he has the pain, you need to assess the pain many conditions. And in patients who are unconscious or semi-comatose, you need to assess that. So these are all certain of the comments as such. And because the pain cannot be assessed objectively, the universally accepted pain scale, which is often used in your research protocols also, is simply the phases of the pain scale, depending upon the facial expression. In a patient who is conscious, this can be, and this is a universal accepted picture, these diagrams of the pain scale, and they usually either 6 scales or 10 scales. Either patient may just verbally express like whether the pain and put on a scale of 10, 0 to 10, or it could be like the facial expression. These are the usual criteria to assess the severity of the pain. And of course, the facial expression can be seen in a real classroom classes. In virtual class, at least we have an advantage where the pain scale may not be assessed directly from the facial expression, but it could be like. Now, the whole mechanism of the pain, to understand the pain relieving drugs or so-called pain killers, analgesics, you need to understand certain of the basic principles of the pain mechanism. And I just have a very brief idea about that, a very brief discussion about the pain, how the pain is sensed and how the pain can be regulated. And then going to the pharmacology of painkillers or analgesics. Now, the sensation of the pain is carried from the cutaneous nerve endings, and the type of the nerve endings would be either pain-free nerve endings or encapsulated nerve endings. These are the basics of the physiology. A sensory cell or free endings as such, and then peripheral process where the nerves would have hairy process. These are the top common types of the sensory receptors at the skin. Free nerve endings, they carry the touch sensation, acute sensation. The encapsulated nerve endings carry the pressure sensation. Fimbriated cells, they carry the vibration sensation. These primary sensory cells, they carry the thermal sensation. So basically, the majority basic sensations are categorized into 4 categories of the nerve endings from the surface of the body, from the skin, as the touch sensation, pressure sensation, then vibration sensation, and the heat and cold sensation. And these sensations are would stimulate these specific nerve endings. Those areas of the body which do not have a free nerve ending, they may not have the pain sensation. Like the gastrointestinal tract, you may not have the pain sensation when the nerve is cut, but because they have a pressure sensation, when the intestine is distended, you may have a pain sensation. If the intestine is cut, stomach is cut, or in a gastroscopy, when you collect the biopsy from the stomach surface, the patient would not have the pain. But if the stomach is distended with gaseous substances, the patient would experience the pain because it has a pressure sensory nerve endings, and so on and so forth. So sensation of the pain is just a modulation of the common sensations otherwise. Otherwise, you will feel the pressure sensation or the touch sensation. A touch sensation which is aggravated, or which is now I'll come to that part, when a touch sensation can become a pain sensation. Due to these multiple theories, you have many theories of that pain sensation, where a normal modality of the sensation itself can be converted into a pain sensation. Now, how to explain this? Contemporary science, physiology, is having lot of theories. Mainly, there are 4 theories of explaining how the pain is felt from the normal sensations as such. Now, one of the theory is the specific theory. Now, among them, the gate control theory is the most popular. I'll come to that at the last. But based upon the other levels of the theories, again, lot of confusing issues are there. The specific theory is was established by Wanfree in 1895, and according to this, there is a specific threshold. According to this specific theory, there are certain nociceptor nerve endings, the nerves which carry the normal sensation. Some of them, they are meant for carrying the pain sensation only, and when there is an increased activity at that area, or if there is more intense sensation, like a touch sensation which is quite severe, if you touch, it is a minor touch, it is a touch sensation. If the touch is more pressurized, or if you touch for either long duration or maybe specific, like now it may be the other way. Certain touches may be painless, certain touches may be painful. Somebody touches you, it may be painful. Somebody touches you, it may not be painful. So on, so forth. So it all depends upon that issue, and that's one of the theory. The specific theory is how you feel about and how that specific nerve endings they get stimulated. Then the intensity theory is the other way, which is again the next popular, which was established in 1874 by Erb. And this says that if there is a very severe or intense sensation of any sort, either it could be the touch or the vibration or the pressure, if there is a high intense sensation, that may produce a pain sensation, that may be converted as a pain sensation as such. This is easily acceptable. Now we can make out that commonly if there is a very strong activation, it produces a pain sensation. Then there is another theory, is a pattern theory, which was established in 1920, and it says that the pattern of the sensation, like a touch sensation, when it is limited to certain area, it becomes innocuous or acceptable. But if it is ranges to some areas, specific areas, or it takes a pattern, if touch is felt in a specific pattern, then that pattern of the pain will be producing multiple neurons and stimulating the multiple neurons, which can result in the pain. This is another of the theory, and this also is quite popular. Then the other theory which is quite popular now, which is more acceptable and very popular now, is the gate control theory. The gate control, which is the latest, of course. It's established in 1965 by Melzack and Wall. And according to gate control theory, the efferent neurons, the nerves, would have a threshold limit. And if the stimulus has reached beyond that threshold limit, then there could be the same sensation can be converted into a pain sensation. The normal touch sensation can be converted into a pain sensation. Threshold limit of these nerve endings may vary depending upon the physiological conditions. So some sensation may not produce the pain today, but next day the same sensation may produce the pain, because the threshold limit could be changed due to the environmental changes in the tissues, or it could be the factors which are in the surroundings, like temperature or other factors there. It also depends upon the psychological condition of the person, that you may feel a pain or otherwise. So that's about the gate control theory. Now, the whole theory of the pain, how the pain is felt, is a very complicated issue from the contemporary science point of view. From Sushruda's point of view, that's a very important issue. Comparison of what you see in the present day and what Sushruda has said. Among the dhamanis, Tiryaga dhamanis, which have thousands and hundreds of the branches around, which surround the surface of the body like a network, and they are those endings of the dhamanis. They are the ones which produce a sensation of either a comfortable or a uncomfortable. A touch sensation or a pain sensation is felt by the same nerve endings. Now, how the same nerve endings would produce, or same dhamani endings, again, dhamanis are nerves or otherwise, another issue. I am not going to that controversy now. So, Tiryaga dhamani and the branches of the Tiryaga dhamani forming a network around the surface of the body, which is something like the cutaneous nerves as such, which carry the sensation, which is comfortable or otherwise. Now, these again, the dhamanis, would be producing that variation in the pain based upon the variables, and those variables are given by Charaka as a Vedat Karyendriyarthanam Bhakvyo Vai Buddhaya Smraha Atmendriya Manorthanam Ekikaha Sanikarshajaha. Atma, Indriya, Mano, Artha, Sanikarsha is the same source, which is a Pratyaksha itself would be producing the pain. So, Pratyaksha and the pain sensation, they are very much similar. And this is compared to a veena or a musical instrument, where you will have these strings which produce variable sounds. In a string instrument, where somebody would be touching that and then producing the vibration based upon the variables. Variables would be the whole length of the string, thread or that whatever that fiber, or again thickness and the tone of that, and the fingers which produce the vibration. So, anguli, the fingers which produce the vibration, and the tala is you will have a moving some instrument which will reduce or increase. That's also called as the bridge. The total length of the instrument, this thread which will vibrate, can be regulated by putting the pressures or having these pedals like pressing upon, and or it could be about the reflected sound in the tambura, that sonorous portion as such. These will produce the difference in the quality of the pain. Now, the same exactly can be compared to our specific theories of pain sensation. The strings, that's the specificity. The strings would have a character of producing some vibration, and that's the specificity theory. Gate control theory is about the tumbar, that the gaur which is over there, which produces a sound or reflects the sound in a resonant fashion. That's exactly the gate control theory. Or the pattern theory is these steps, multiple steps which you see, and based upon that you have either the madhyama, mandra, or stara, etc. varieties of the sounds produced, and the intensity is the total amount of the vibration, pressure, anguli. Now, so theory of pain sensation which is present in the contemporary system, which is described in the contemporary system with a lot of confusion, is better explained from Ayurvedic point of view. That's a very highlight. So though in emergency medicine discussion, this may not be relevant, but I have referred to this issue because it's one of the highlights which we can highlight as such. Now coming back to the management of pain from the practical point of view, the classification of the chronic pain in the International Association of the Pain Sensation would be, it's based upon these 7 categories, and these are the categories of the pain which help in planning the management. Would be either relatively generalized syndromes, that's where the patient may have the pain throughout, something of that sort, where the patient may not be able to point out the pain at which area, and localized syndromes of the head and neck, or the pains of the spine. Again, have 2 categories, spinal and radicular pain, or radicular pain with the cervical and thoracic region as the category 2, section 2. Local syndromes where upper limbs are relatively generalized and or maybe part of the upper lower limbs. Visceral and other syndromes are categorized as the pain 5 category. Spinal pain, the section 3 is radicular pain syndromes with lumbar, sacral and coccygeal. Majority of the patients with low backache, the spinal injuries or disc lesions are these conditions. Local syndromes of the lower limbs where there could be pain sensation as such. Now, once the pain is produced and we in the local area, it's carried from through the nerves to the spinal cord. From the spinal cord, it ascends up to the thalamus. In the thalamus, it's interpreted and it reaches to the limbic system and the sensory cortex. Ultimately, the pain is felt at the sensory cortex. And the pain is modulated. The intensity of the pain is modulated by the descending pathway. The descending pathway from the ganglions would be producing or reducing the intensity of the pain or enhancing the intensity of the pain. This is in brief about how the pain is felt. Now, as far as the pain management is concerned, now we'll directly go into the pain management. Physiology of the pain will stop at that level. Pain management is concerned, you can reduce the pain at different levels. Pain sensation can be reduced at different levels. So the first is at the level of the injury, at the site of the injury. Once there is an injury, there will be tissue amines released, and these tissue amines will produce the stimulation of the nerve endings. Now, this injury, at the site of the injury itself, the pain sensation can be minimized either by application of the cold or the heat or local anesthetics. Local anesthetics like lignocaine, which will reduce the stimulation of the nerve endings. It blocks the nerve endings from getting stimulated by the mediators of the pain. So, cold and heat can reduce the release of these energy, tissue amines at the time of the injury, either reduce or modify that. Then comes the nerve block. Conduction of the nerves, the impulses through the nerves, they can be blocked by what we call as the nerve block anesthesia, like the spinal anesthesia or so on. Or the pain intensity can be modified by adrenergic drugs or opioids. Opioids and adrenergic drugs, they will make or stimulate these ganglions, and hence the patient would not feel that acuteness of the pain. The whole mechanism of the pain would be present, but the severity of the pain may not be felt by the adrenergic drugs when adrenaline is given. Some of the opioids, or then there is another issue called as a placebo. Placebo is simply, again, categorized in, there is a lot of confusion about that word placebo, but people say that Ayurvedic medicines are placebos. Now, whether it's that way or not, that other way, whether the Ayurvedic drugs are placebo or not, it's not the important issue. The issue is where you do not know the specific activity of the drug, but it reduces the pain. It can be reducing the severity of the pain, though the mechanism of the pain producing pathology does exist. It may remain everything otherwise may be looking same pathway, the intensity of the pain, passage of the pain sensations and the sensory cortex, everything is not same as such, doesn't change, but the patient may not feel the intensity of pain. Now this is a very common example. Patients who are in the postoperative phase, many times simply a casual talk with the patient itself can reduce the pain. A joke with the patient can reduce the intensity of the pain. These are all the issues which may be easily considered as placebo, so that the reaction of the patient to the pain can be reduced. Then, of course, you can block the sensation of the pain in the spinal by spinal or epidural anesthesia, or the general anesthesia is at the cortex level. So-called analgesics. Now we will come to that. Non-steroidal anti-inflammatory drugs and analgesics, they have a pain modifying activity. They are not really pain blocking. They have a pain modifying activity where either these tissue amines are released or tissue amines action on the nerve endings could be modified as such. Then, of course, the issue of yoga, meditation and samadhi, which can reduce the intensity of pain, is not at all described or not at all known in the contemporary science. Contemporary science is totally blind about that. But it's true. Meditation, yoga or samadhi that can reduce the intensity of pain. We have seen many experiences of that. I have a direct experience of operating on a fully conscious patient, hydrocele operation in a fully conscious patient without any anesthetics. And even if I squeeze and then pull the cord, patient never had that experience of the pain. So these are something where the contemporary science and the contemporary physiology cannot reach to that area, but the fact is there. So that's another issue. So I will not waste much of the time. But when it comes to the question of pain management, this also has a role in certain extent. How you benefit it, how you use it, that all depends upon your experience. Now that's one part. Now we directly go into the real subject, real topic, the pain relief. And the commonest thing which we do in a common man when there is a pain would be either applying some heat or cold. It's a very common experience. Applying some cold or heat is a very common issue. When to apply the cold or when to apply the hot? Which pain can be modified by the cold? Which pain can be modified by the heat? This is another of the area of confusion. Very commonly people will not have that discrimination, and maybe they may use it randomly. But primarily from the physiology point of view, a chronic deep-seated pain can be managed better with the heat, whereas an acute pain produced due to injuries, it can be reduced by a cold. So cold helps in reducing the acute pain where there is a immediate release of these tissue amines. So in the cold condition, because the blood flow to that area can be reduced, the release of tissue amines can be reduced, and the tissue amines may not be, that mediators of the pain may not reach to the nerve endings to the same extent as otherwise. It's not that the cold will stop the pain sensation completely. At the same time, the cold also will be reducing the action potentials in the nerve endings. Threshold of the nerve endings also can be enhanced in cold so that the sensations may not be carried. Of course, in an extreme cold condition, the nerve endings may be dead and then there may not be any sensation at all. Whereas the heat is used for chronic deep-seated pains. Chronic deep-seated pain like arthritis, headache and sprains and so on. Warmth can be pain, reducing the pain, where it actually modifies the pain sensation. Nerve endings, their sensation is nerve endings capacity to carry would be modified, and rather it also acts by a counter irritant mechanism. Applying the heat can act as a counter irritant mechanism. Now counter irritant, again I will come to that somewhat in detail. So heat would be acting both as counter irritant and also it will modify the nerve functions so that the sensitivity of the pain would be reduced. And the common conditions where heat is preferred is in arthritis, like where you may have that swetha, nadi swetha and so on, or headaches, strains, etc. Now whether that would be producing a long relief of the disease or the pain relief is the other issue. Now these are only for the pain relief. It's not about the disease modification. Disease is not altered. Pathology for the pain is not altered by this, but the intensity of the pain felt by a person can be modified, and hence the patient's condition can be comfortable. In acute conditions like a sprain, tendinitis, or maybe acute wound, or in migraines also, it can be cold can be used usually as such. Then coming to the other drugs, the pain relieving drugs, pharmacology of pain relieving drugs. Pain relieving drugs also are categorized as anti-inflammatory drugs. Some of them also are antipyretic because their mechanism of action would be very much similar to or rather they will be acting upon the tissue mediators of the pain, and hence these are used. Among those drugs, again there is a huge list of such drugs. I will not go into all of them. I will be limiting to only the most commonly used drugs, frequently used drugs in the regular clinical practice. Among them, the most commonly used drug is paracetamol or acetaminophen, which is almost something like the salt used in kitchen. Every person would be using this paracetamol regularly, and the mechanism of action is it acts by there are two issues. One, hypothalamic heat regulatory center. It acts on the hypothalamic heat regulatory center, as well as it also can be reducing the intensity of the pain felt at the thalamus, because it acts on the thalamus. Its more obvious effect is it reduces the heat, it affects the heat regulatory center, and hence in a patient who has a fever, the temperature is reduced by making that thermoregulatory center less active. It also produces it's not an anti-inflammatory, doesn't reduce the inflammation, but it also acts upon the tissue amines to a certain extent. But whether it reduces the tissue amines or not is still questionable. Some people say that it reduces the tissue amines, or some people say that it doesn't. And the indications, of course, are like any febrile condition to reduce the temperature, or it also can be used for a moderate intense pain. For moderate intense pain, it's used, and the dose, the maximum dose, just about the maximum dose is about 4 grams in adults maximum, whereas the usual dose is 250 to 500 milligrams, and in patients with alcohol, it should not be given in high doses. The dose should be reduced. Most important contraindications of the paracetamol are it's allergic to acetaminophen, and it can also produce a hepatic function, persons with the hepatic function irregularity, chronic alcoholism, pregnancy, lactation. It should be given carefully. It can produce harmful effects. And another quite important harmful effect of the paracetamol, which is not mentioned in the pharmacological textbooks, would be like a patient who takes paracetamol and the fever is reduced, his appetite will be completely lost, and though the patient doesn't have a fever, he may not have the same activity, physical activity may not be the same. It also can produce some confusion, as such. And skin rashes, renal damage also do occur quite frequently in patients with the paracetamol as such. So that's about a brief of pharmacology of paracetamol. Another common and rather oldest of the drugs of among these would be salicylic acid, or it's also called as aspirin, the other commonly used non-steroidal anti-inflammatory drugs. It inhibits synthesis of the prostaglandins. Now, one of the neurotransmitter which is released at the site of injury would be the prostaglandin. Prostaglandin will produce a burning sensation, picked as a variety of the sensations. I think something which we have discussed in some previous occasions. Now, that prostaglandin synthesis is inhibited so that the amount of the tissue amine released at the site of the injury is reduced, and hence it reduces the pain sensation. At the same time, prostaglandin also has another role of stimulating the platelet aggregation. Now, because it reduces the prostaglandin, as well as it also has a direct effect on the platelet aggregation, it reduces the platelet aggregation and has a mild anti-thrombotic activity. So, aspirin now, in the present day situation, is more frequently used for the anti-thrombotic activity than really the relief of the pain, because you have many other more potential pain relievers. But in earlier days, salicylic acid or aspirin was the most commonly used and pain relieving drug. Even now, we do still use in certain specific conditions. Now, the specific indications are rheumatic fever. In the pain produced to the rheumatism, salicylic acid has a very specific role. In all other fever conditions, aspirin was being used. Now, of course, not as very popular, not as popular as paracetamol, but it can be used, and it's also used for relief of the moderate pain, mild to moderate pain, particularly deep seated. And the other benefits are it also reduces risk of strokes, and it reduces the possibility of myocardial infarction in patients who have a tendency, and that the dosage for antiplatelet factors would be low dose 25 milligrams per day or 75 milligrams per day, whereas for the pain relieving and rheumatism, treatment of rheumatism, it's a high dose like 2 to 4 grams. So based upon the doses, it can be varied as such. And most of the times it's given orally, and usually it's given after food because it has a max gastric irritant factor. It's usually given after food, and it has to be given with the sufficient quantity of water because it's acidic in nature and can produce erosion of the stomach mucosa. Aspirin tablets are usually having a coating so that it directly gets digested in the stomach. If you crush or chew the aspirin tablets, then the salicylic acid will be acting on the oral mucosa, can produce ulcers, and hence they should not be chewed. Certain preparations are available as a chewable where the coating is thicker, so that's another issue. But majority of the conditions, the aspirin tablets are to be swallowed directly, and very often patients who chew the tablet or crush the tablets, they tend to develop the ulcers in the mouth. Contraindications are patients who have a tendency for bleeding and clotting deficiencies. It can produce a more bleeding, and the patients who are supposed to undergo surgery, and if the patients are on aspirin, it's better to withdraw that for at least 1 week. So, or at least 2 doses of aspirin has to be blocked before you go for a surgery. And pregnancy, breastfeeding also used in, and patients with chickenpox or flu symptoms, it can enhance the chance of acute hepatic failure, that's Reyes syndrome. Aspirin can result in this adverse effect of Reyes syndrome, as well as it can produce the hemorrhage, seizures, or even bronchospasm, and gastric irritation like nausea and hepatotoxicity. They are very common, and it can produce a dizziness and tinnitus, which is also called as salicylism. These are the important basic highlights of the pharmacology of salicylic acid. The other NSAIDs, group of that, will continue in the next session. Again, very brief, and many of these are quite popularly used. And that would be our last session on emergency medicine when we discuss this. With this, we'll conclude today. If there are any questions, I'll try to answer. Sorry, no questions. So we'll stop now, and we'll continue in the next session. And that would be the last session on emergency medicine. Right.